Welcome to this custom-tailored deep dive. We are so glad you're here with us today.
Yeah, thanks for tuning in, everyone. We've got a really fascinating topic today.
We really do. So normally, right, when you think about physical rehabilitation or building strength, you have this very specific, culturally ingrained image in your head.
Oh, totally. You picture someone sweating in a gym, lifting heavy weights, pushing through the burn.
Exactly. The basic rule of thumb we've all been taught is that tension equals strength. You clench, you lift, you get stronger.
Right. We're basically conditioned to believe that tightness is the ultimate sign of a, highly functioning, powerful body.
But today's mission is to unpack a highly specific yet deeply transformative area of pelvic health. And when you step into the world of pelvic floor rehabilitation, suddenly that entire gym culture playbook is just thrown right out the window.
It really is. It's a complete 180.
We've been looking through the latest clinical guidelines from Europe, the National Institute for Health and Care Excellence, and some major physical therapy protocols. Plus, this massive multidisciplinary protocol from Indonesia.
Yeah, the data in those sources is just incredible, especially the patient surveys on device usage.
And what you realize reading through all this is that we're looking at a clinical landscape where the secret to strength and healing actually requires doing the exact opposite of a workout.
Right. And I can promise you, by the end of this deep dive, you're going to understand why. We're talking about conditions where fear and pain have created a literal physical lockdown in the body.
A complete lockdown.
Yeah. And the treatment requires a delicate rewiring of the nervous system where replacing fear with absolute autonomy is the key to unlocking that tension.
So before we even touch on the medical devices involved or, how clinicians actually pull this off, we have to fundamentally reframe how we think about the pelvic floor itself.
We really do, because it functions in a way that just counteracts all our usual assumptions.
Like we said, we associate tight muscles with strong muscles.
Mm-hmm.
But the clinical literature is very clear here. That is a total myth when it comes to the pelvis.
Complete myth. A chronically tight pelvic floor is, in reality, a weakened one.
Which sounds backward.
I know, it does. But think about how any muscle is supposed to work. I mean, it needs to be able to contract to generate force, sure.
Yeah.
But it also has to fully relax and lengthen to complete its full range of motion.
Right.
The pelvic floor is this complex hammock of 14 different muscles that support your pelvic organs. So when you have an overactive pelvic floor, those muscles are essentially stuck in a contracted, shortened state.
They're just clenched all the time.
Exactly. And because they're chronically tense, they can't function properly, they can't support the organs, and they trigger a whole host of secondary issues.
The sources mention things like chronic pelvic pain, urinary incontinence,
Yeah.
and severe pain during intercourse, right?
Yeah. And vaginismus is actually a prime example of this dynamic that comes up a lot in the clinical guidelines.
Which is when the muscles spasm involuntarily.
Right. It's a condition where the pelvic floor muscles involuntarily and reflexively spasm in response to just the anticipation of vaginal penetration.
So it's not like the person is choosing to tense up.
No, not at all. It's not a conscious clenching. It's an automatic neurological lockdown.
It makes total sense when you map it onto the rest of the body. Like, I always think of it like walking around all day with your shoulders completely shrugged up to your ears.
Yes, that is the perfect analogy.
If you hold that for 8 hours while you're typing at your desk, your shoulders don't turn into superhero muscles.
No, they don't.
They just get exhausted, rigid, and incredibly painful.
And just like those shrugged shoulders, pelvic tension is deeply tied to the nervous system. The chronic tightness is linked to the sympathetic nervous system, the fight or flight stress response.
So the brain perceives a threat, and the body physically armors itself.
Exactly. So before a clinician can even think about introducing physical therapies or desensitization, the absolute first step in rehabilitation is what they call down training.
Down training.
Yeah. It's the process of teaching these muscles how to consciously relax and return to their natural, elongated resting position.
So you're intentionally calming that fight or flight panic.
Right, and trying to activate the parasympathetic nervous system, which is our rest and digest state.
Okay, but here's the thing. With my shoulders, I can see them in a mirror. I can physically feel them creeping up to my ears, and I can consciously drop them.
Right.
The pelvic floor is hidden deep inside the body. So how do you tell an invisible muscle to just let go?
That is the core challenge for physical therapists. Because you can't easily see it or point to it, therapists have to build a really profound brain-body connection from scratch.
And how do they do that?
Well, the foundational tool they use is diaphragmatic breathing, which is often just called belly breathing.
Breathing sounds so simple, almost too simple, you know?
It does sound simple, but the mechanical chain reaction it causes is wild when you look at the anatomy.
Oh, wow, really?
Yeah, so the diaphragm and the pelvic floor work together like a piston inside your torso.
Yeah.
When you inhale deeply into your belly, taking a proper diaphragmatic breath, your diaphragm moves downward.
Right, it pushes down.
Exactly. And because of the pressure changes in your abdomen, this physically forces the pelvic floor to lengthen, yield, and release tension.
Oh, I see.
Then, on the exhale, both the diaphragm and the pelvic floor naturally draw back upward.
So by controlling the breath, you're mechanically forcing the pelvic floor to stretch and relax.
Yes, you're bypassing the fact that you can't consciously flex it the way you would, like a bicep.
That's fascinating. But still, feeling that internally must be hard for a beginner.
It is. So to help the brain visualize this invisible area, clinicians use highly specific biofeedback.
What kind of biofeedback? Like machines?
Yeah, they actually place external sensors near the pelvic floor muscles, and those sensors are hooked up to a monitor. The patient can watch a line on a screen that represents their muscle tension.
No way, so you can see your own tension in real time.
Exactly. When they subconsciously clench, the line spikes up, maybe turns red. When they take that deep belly breath and the pelvic floor yields, the line drops and smooths out.
That is so cool. You're literally watching your invisible nervous system on a screen.
Yeah, and that real-time data is incredibly validating for someone who feels disconnected from their own body. Clinicians also pair that biofeedback with really vivid verbal imagery.
Imagery like what?
The physical therapy protocols mention using scripts that compare the pelvic floor to a jellyfish gently pulsing in the water,
Oh, I like that.
or a blooming flower opening its petals, or even an elevator gently descending from the penthouse to the ground floor.
Okay, I have to push back just a little bit here based on the sources.
Sure.
Breathing and watching a line on a screen, or imagining a beautiful blooming flower, that sounds incredibly relaxing.
It is.
But we are talking about patients who are dealing with severe trauma, chronic pain, or what one of the case studies calls grade 3 vaginismus,
Right.
where the involuntary muscle spasms are severe enough to make any physical contact basically impossible. So is breathing and imagining a jellyfish really going to fix involuntary spasms?
Well, no. It isn't enough on its own to cure severe pain or advanced vaginismus.
Okay, so what is it then?
The down training, the breathing, the biofeedback, the mindfulness, it's just phase 1. It establishes a baseline of neuromuscular control. You cannot systematically desensitize a muscle that is actively guarding and locked in a panic state.
Oh, I get it. It's the prerequisite. You have to learn how to find neutral before you can put the car in drive.
That's a great way to put it. Down training creates the foundational environment where the next phase of therapy can actually work, and that next phase is the physical intervention.
Right, which involves a systematic desensitization.
Exactly. Once the patient can find that baseline of relaxation, the clinician has to help them apply it to actual physical sensation. And this is where medical-grade dilators enter the picture.
Okay, let's talk about that. Because think about how counterintuitive and frankly terrifying this must be for the patient.
Oh, absolutely.
The brain has locked the pelvic floor down because it is terrified of penetration.
Yeah.
And the medical treatment for this fear is penetration.
Yeah.
You're basically asking a patient to purposefully trigger their own phobia.
It is an immense psychological hurdle, which is exactly why the design of the tools and the way they're introduced is meticulously controlled.
So what are these dilators exactly?
Vaginal dilators, sometimes called vaginal trainers, are smooth cylindrical devices. They're usually made of medical-grade silicone or hard plastic.
And they come in different sizes.
Yeah, they come in sets of progressive sizes, starting from very small, sometimes as narrow as a pinky finger, and gradually increasing in diameter.
The clinical guidelines we read are very explicit about what these devices are doing. They are not forcefully stretching the tissue like a shoe stretcher.
No, definitely not. The goal is never brute force. The purpose of the dilator is to provide a gentle, manageable stretch stimulus that gradually diminishes the brain's fear response.
So it's about breaking a habit.
Yes. It's designed to interrupt that painful cycle of hypersensitization and reflexive muscle guarding. The brain expects pain, so it clamps down the muscles, which then causes actual pain when contact is attempted.
Which just reinforces the fear all over again.
Exactly. The dilator breaks that loop by providing contact without pain.
It's essentially exposure therapy.
That's exactly what it is.
If you have a severe phobia of dogs, a therapist isn't going to just throw you into a pen full of jumping golden retrievers.
Right, that would be a terrible
It
idea.
would completely traumatize you. You start by just looking at a picture of a dog while doing your deep breathing.
Yep.
Then, maybe a week later, you sit in the same room as a dog that's fast asleep in a cage. You slowly, incrementally build up your tolerance while keeping your nervous system in check.
That is the exact psychological and neurological mechanism at play here. It's about teaching the nervous system that this specific physical sensation is actually safe.
And the technology around this is evolving too, right? Because the sources highlight a relatively new device called the Millie.
Oh yeah, the Millie is fascinating. It's a huge step forward for making that incremental progression even smoother.
Wait, I remember reading through the notes on the Millie. This is a single device, not a set of different sizes, right?
Right, it's just one device.
So how is that better than just buying a standard set of dilators?
Well, think about it. Traditional static dilators can be incredibly frustrating. You might master the smallest size, say the blue one, and feel really good about your progress.
Okay.
But then you look at the next size up in the box, the pink one, and it just looks too big. The jump between static sizes can feel like a massive, intimidating leap.
And that triggers the anticipatory anxiety all over again.
Exactly. The Millie solves this because it's an electronic dilator that is entirely patient-controlled. You insert it at its baseline size, which is just 15 millimeters.
Oh, that's pretty small.
Yeah. And then, using a handheld controller at your own pace, it expands electronically in tiny 1 millimeter increments up to 40 millimeters.
Wait, so it expands while it's already inside.
Yes, exactly.
That microadjustment means you never have to make a sudden, scary jump to a totally different device. You just dial it up a tiny bit.
Right. It allows for this microscopic level of progression that traditional dilator sets just can't offer. It also features optional vibration, which research shows can further help relax the tissues.
And distract the local nerve endings from the sensation of stretching, probably.
Exactly.
But this still brings up a massive logistical hurdle. I mean, even with an amazing tool like the Millie, we are talking about introducing a physical device into an area that the patient's brain deeply associates with severe anxiety.
Definitely.
Even just the thought of the doctor's appointment could trigger that exact fight or flight response. They just spent weeks learning how to calm down with the biofeedback.
For sure.
So how do clinicians actually execute this first step in practice without re-traumatizing the patient?
To understand that, we can look at a truly fascinating approach detailed in our sources. It's the Assisted Dilatation Multidisciplinary Protocol.
That's the one from Indonesia, right?
Yeah. Yes, from Indonesia's largest dedicated center for vaginismus. This protocol gives us a window into the exact clinical environment required for success, and I have to say, it is radically different from a standard doctor's visit.
Reading about the level of care and the environmental setup, it's just incredible. It's not just a quick 15-minute appointment.
Oh, not at all. In this protocol, the patient is transferred to a private, en-suite room in the gynecology ward. They are often admitted for at least 24 hours.
A whole 24 hours just to get comfortable.
Yes. The environment is designed to feel safe, unhurried, and dedicated entirely to their comfort. The consultant gynecologist is present in the room during the first supervised session. But here is the critical part.
Okay.
The clinician provides only verbal instructions and empathetic reassurance.
Wait, the doctor doesn't perform the procedure? They never physically intervene?
Never. The clinician is there to continuously assess the patient's anxiety, monitor their eye contact, watch for any involuntary muscle spasms, and guide their breathing.
But the physical part?
The patient independently holds, inserts, controls, and rotates the dilator entirely on their own.
I really want to highlight how profoundly empowering that is.
It's amazing.
Because in a traditional medical setting, especially in gynecology, things are often done to the patient. You lie back on a crinkly paper table, you put your feet in cold metal stirrups, and the doctor performs the exam while you stare at the ceiling.
Yeah, the power dynamic is usually completely lopsided.
But this multidisciplinary protocol is reverse engineered around absolute patient autonomy.
Yes, and the underlying philosophy here is what makes it so effective. As one of the clinical reviews points out, the core goal of dilator therapy isn't just mechanical stretching. The true goal is literally replacing fear with control.
Replacing fear with control. I love that.
Right. By giving the patient complete autonomy over the pace, the depth, and the removal of the device, you're interrupting the anticipatory trauma.
Because if they feel a spike in panic, they don't have to verbally communicate that to a doctor, hope the doctor understands, and wait for the doctor to stop.
Exactly. They're already holding the device. They can stop it themselves instantly.
That instant, undeniable control is what tells the nervous system, I am safe. I am the one deciding what happens to my body. It's brilliant.
It really is.
So the clinician acts as a guide for that crucial first step in a safe hospital environment. But if the doctor is entirely hands-off, that means the burden of the actual physical therapy falls entirely on the patient when they go home.
That's right.
You don't cure a chronic pelvic floor issue in one 24-hour stay.
Yeah.
So how do people handle that kind of pressure alone in their own bedroom?
The clinical guidance transitions heavily into an at-home practice, and the rules for this are very clear across the physical therapy protocols.
What are the main rules?
First, copious amounts of water-based or silicone lubricant are required. You have to reduce any friction that could trigger guarding.
Makes sense.
Second, start small and slow, always spending time down training and doing the diaphragmatic breathing before even attempting insertion.
Getting back to that neutral baseline.
Exactly. And third, never push through sharp or escalating pain. Mild pressure or a stretching sensation is expected, but sharp pain signals an immediate need to stop, breathe, and regroup.
And the golden rule they all seem to emphasize. Consistency over duration.
Yes, that is key.
It's better to practice 3 to 5 times a week for just 10 to 15 minutes a session, rather than trying to power through an agonizing hour-long session once a week.
You are retraining the brain, and the brain learns best through consistent, repetitive, non-threatening exposure. But, this transition to home practice brings us to one of the most surprising insights in the data.
Oh, about how patients behave when no one is watching.
Yeah. There was a 3-month survey of patients using the Milli dilator at home, and it tracked not just how often they used it, but what they were doing while using it.
And the results completely blew my mind when I read them.
Right. The survey found that a large number of women naturally tried to distract themselves during their therapy sessions. They would watch TV, stream videos on their phones, or read a book while the dilator was inserted.
Which, logically, you can totally understand why someone would do that. If I have to do something that makes me intensely anxious or even slightly uncomfortable, my immediate instinct is to put on Netflix and just zone out until the timer goes off.
Yeah, exactly.
It's the ultimate human survival strategy for discomfort. Just dissociate until it's over. But the data shows that is the worst possible thing you can do for this specific therapy.
It is. The survey revealed that patients who distracted themselves by reading or watching TV actually had significantly worse results.
Worse?
Yes. They experienced less reduction in pain, less reduction in anxiety, and they struggled far more to progress with the dilation compared to those who didn't use distractions.
But why does distraction sabotage the therapy? Like, if the muscle is being gently stretched by the device, shouldn't the physical stretch work regardless of whether I'm paying attention to a sitcom?
Well, this highlights the critical difference between mechanical stretching and neurological retraining. If this were just about stretching a piece of inert rubber, then sure, distraction wouldn't matter. But we are dealing with a complex brain-body feedback loop. Systematic desensitization requires retraining your nervous system to feel safe with the physical sensation.
So you have to actually feel the sensation to teach your brain that the sensation isn't a threat.
Exactly. If you completely distract your brain with a screen, you're zoning out. You aren't present. Therefore, your brain isn't consciously processing the physical pressure, and it isn't learning that the pressure is safe.
So the fear loop stays intact.
Yes. The neural pathways associated with fear and muscle guarding are never actually overwritten because the brain is busy watching a movie.
That is wild. You can put in all the time, do the 15 minutes, 5 days a week. But if you aren't mentally in the room, the therapy essentially stalls.
Pretty much. The best results, according to the data, came from patients who stayed entirely present. They were the ones who combined the physical dilation with the active downtraining techniques they learned in the clinic.
So they were doing the breathing exercises at the same time.
Yes. They practiced mindfulness, they listened to soothing music without lyrics, and they focused intensely on their diaphragmatic breathing. They actively participated in the feedback loop between their brain and their pelvic floor, consciously reminding their body to yield to the pressure.
That requires an immense amount of bravery, to sit quietly in a room, feeling a sensation that your body has spent years telling you to run away from, and actively choosing to breathe into it instead of checking out.
It really does. It's incredibly brave, and it underscores the ultimate takeaway from all of these clinical guidelines and therapy protocols. Successful pelvic floor rehabilitation requires treating the brain and the body as a single, inseparable unit.
You just cannot force the body to comply if the brain is terrified.
No, you really can't.
It always comes back to the brain. We started this deep dive talking about the myth of the gym workout, the idea that you can just force a muscle into submission to make it stronger.
And we've seen how that's just not true here.
Right. What we've seen in the sources today is a totally different path to healing. It starts by downtraining the nervous system, learning how to drop the tension, and find that baseline of relaxation using biofeedback and breath.
Then it progresses to gradual, systematic desensitization with the dilators.
Yep.
And it relies entirely on the patient having complete autonomy over the process, replacing fear with control, and combining that physical tool with mindful, consistent presence rather than forceful distraction.
It's a powerful lesson in how our bodies actually heal when we stop fighting them and start listening to them.
Absolutely.
And that brings us to a final thought for you, the listener, to ponder long after this deep dive ends.
A little something to mull over.
Exactly.
Yeah.
We've spent all this time exploring how the brain and the pelvic floor are so deeply, intricately hardwired together that an emotional state like fear or even just anticipatory anxiety can cause a physical structural lockdown of the muscles.
Which is pretty mind-blowing.
It makes you wonder what other hidden areas of our bodies are quietly holding onto our subconscious stress. What other tensions are we walking around with, completely unaware, just waiting for us to finally learn how to downtrain them?
That is a great question.
So take a deep breath, drop your shoulders, and we'll catch you on the next deep dive.